Okay. Um, Y'all asked me about newborn care and feeding. We go over the right, but I want to make sure that before you need to know any questions. I mean, if you have seen all this going in the hospital, it should be all right. We've talked about admission of the baby, and the gestational age, and we're making sure that the baby's adapting to extrauterine life. So I'm not going to spend a lot of time talking about that again. We've talked about APGAR. If we have to do any kind of resuscitative measures, we're going to do the exam, vital signs, make sure the baby's voiding, and make sure passing ammonium. So during labor and birth, any kind of assessment data that we can obtain from the labor record, we need to know all of these things so that we can take better care of the newborn. Are they rooming in? Are they going to have a circumcision? We've talked about deciding on what type of feeding. Are there any children at home? What's her support system? Are we seeing some problems with her interaction with us, with the baby, with other people? Are there any situations that might compromise her being able to breastfeed? Or are there any high risk problems that we need to know about? We talked about all of these already too, um, doing the physical assessment and getting blood sugars, gestational age, and definitely monitoring the temperature. Now, your book says a little bit different than what we might say in the hospital. So we will go by what your book says, that we will take the temperature and vital signs every 30 minutes until the baby is stable for at least 2 hours. Okay, and we've talked about all these things many, many times already as well. Respiratory distress, we said we're going to clear secretions with a bulb syringe, and you may see in the hospital they may use deep suctioning. The delay suction is for meconium. Another way we can help the baby to clear is by just stroking the newborn's spine, and oftentimes they'll clear themselves. There is evidence out there in the literature that you may like response. If the response that is clearing secretion on their own, we talked about vitamin K and eyes already. Um, we want to initiate feeding as soon as it's appropriate to do so. We want to facilitate that attachment to the mom and the family, eye to eye contact. But if there is respiratory distress going on or something else, then bonding, as soon as both are stable, then we will try to initiate that. And we want mother to be involved in bathing, so we might can wait on that until she is able. So we talked about vital signs already. Skin color every 4 hours. We'll do a TPR every 8 and blood pressure PRN. Lungs we're going to listen to every 4. Look at their eyes, umbilical cord, and any increased mucus. Apical pulse is going to be every 4, looking at their movements and reflexes. How does the suck and swallow during feeding, especially if they're breastfeeding? Temperature before and after the bath. Any jaundice, sometimes you may not see it yet in the mucous membranes, but you can touch the nose, and if it's yellow, then you know the baby may be getting jaundiced. Of course, metabolic screening and hearing tests are important. Before they go home, we need to get one more weight. Take the cord clamp off. Don't send it home with them. Teach them on circumcision care if we did one. And Teach them that this baby can feed on demand about every 3 to 4 hours. Is it okay for those babies when they go home initially to sleep all night without being fed? If they're a breast baby or a bottle baby initially, no, we need to wake them up so that they can eat. Ongoing skin care for the behind and the perineal areas, but no powders. Hep B as ordered. We're going to have to review any teaching. We may have to reinforce. How's the home? Um, Someone from medical records will come about the birth certificate, and we're going to have to see, are you anxious about taking this baby home? Do you understand what's going on? Um, Cues to look for when the baby's hungry, different things like that, instead of just shoving them out the door. Our goals, of course, are that the baby has a good cardiopulmonary function, a neutral thermal environment, adequate hydration and nutrition, so that we can help prevent any complications and mom is taking this baby home to a safe environment. Breastfeeding. Human breast milk is the ideal, specifies, is specific to any human baby. Both hospitals are breast friendly hospitals, except one of them, it requires an order for mom to be able to formula feed their baby, and you can decide how you feel about that. Breast milk has over 200 distinct components in it. It's a high lactose content and it contributes to brain and CNS development. This is why we ask moms to pump when their baby is in NICU so that we can give the babies the breast milk. If babies breastfeed, they're at reduced risk for type 1 and 2 diabetes, lymphoma, leukemia, and Hodgkin's, obesity, hypercholesterolemia, and asthma. And mother has a reduced risk for postpartum bleeding, and her uterus would go back into shape more quickly. A reduced risk of breast cancer and ovarian cancer, and it may be associated with a decrease in type 2 diabetes, rheumatoid, or hypertension. Now, do people still get breast cancer and ovarian cancer and diabetes even though they breastfed? Sure, they do, but their risk is decreased. The baby gets immunologic advantages from breastfeeding, decreased respiratory tract and GI infection, NEC, necrotizing enterocolitis. This is another reason we try to give breast milk to our NICU babies. UTIs, otitis media, meningitis, bacteremia, as well as allergies. IgA is also gotten from breast milk, which is an antiviral, antibacterial, and antigenic inhibitor. Psychosocial advantages for some women. This is not for all. It increases their self esteem because they're doing something for their baby and it enhances their bonding with the infant. It helps in stress reduction, helps the mother feel like she has accomplished something and she's got closeness and more warmth with her baby. And it helps her to learn more about her baby, what's the baby's behavioral cues of when it's hungry, when it's upset. And it also releases prolactin and oxytocin. So this helps mother feel more affectionate towards the baby, helps improve the letdown reflex so that the milk comes in, and it will help to breastfeed more frequently and longer whenever there's a release of the prolactin and the oxytocin. Of course, it's a cost savings. We're not having to buy formula, and you don't have to prepare. You just have to make sure you stay clean. Disadvantages. Sometimes cannot breastfeed if she has HIV or AIDS, if she has active tuberculosis or varicella, human T lymphocyte virus, which is HTLV1 positive, or if she has herpes on the breast. If she takes drugs, or she's an alcoholic, a smoker, or certain prescription meds, she cannot breastfeed. If she has breast cancer, or if the baby has galactosemia, no breastfeeding. Formula feeding advantages: whenever she doesn't have breast milk available, or when she's sick, or when she's having to take medications, or there's something wrong with her breast that she just can't lactate, like a surgery or some type of endocrine disease. Formula provides adequate nutrition. Both parents can feed the baby and develop that positive interaction with the baby during feeding. And the mother doesn't always have to be there. If she has to, somebody can give that baby the bottle. Disadvantages: this formula is derived from bovine milk or plant sources. Um, Not as many nutrients in formula. There's additives in there. It's missing some ingredients. And nutritional adequacy sometimes depends on the proper preparation, especially if mama is preparing that powdered formula. It has to be almost exact to be the way it should be. Overfeeding sometimes happens when we're doing formula. When baby cries, we think it's hungry and we're not paying attention. Hey, you just fed the kid 30 minutes ago. Sometimes they may feed the baby not enough. Formula doesn't have anti-infective properties. Um, Sometimes formula is linked to increased respiratory their potential formula. The formula, according to this source, about $1,400 a year if we're having to buy hypoallergenic formula. Uh, there's other costs, bottles, refrigeration is needed if you're preparing more than one at a time. Of course, we have to buy it. And preparation is time consuming and it's not very convenient if you're traveling and then if you have to get up at night and your bottle. So I have to decide if when is this baby ready to feed. Active bowel sounds, abdominal distension? Do they have a lusty cry that quiets and is replaced with rooting and sucking? If I tickle the side of their cheek and they start rooting, then I know baby's probably hungry. So then I place a stimulus near the lips, which is a nipple or a bottle, and the baby's going to start sucking. Skin to skin contact can start immediately after birth, and if you've ever watched the little baby crawl right after it's born, you put a baby skin to skin on mom's belly and it'll scoot until it gets up to mama's breast and start breastfeeding. And we can start breastfeeding in the labor room. Formula fed infants are fed according to hospital policy. For breastfeeding and bottle moms, early feeding enhances that attachment. So if the baby is stable, we advocate for that because it will stimulate peristalsis and it helps to get rid of those byproducts of bilirubin conjugation, which decreases the risk of jaundice. So the quicker we can start feeding the baby so it can start getting rid of this excess bilirubin, the better. On demand feeding is whenever the baby's hungry. Cluster feeding is normal in the beginning for breastfeeding, 5 to 10 feedings over 2 to 3 hours, because that'll help stimulate milk production. And sometimes you're going to have to teach the mama how to wake this sleeping baby up because if it hasn't been eating enough or just tired, we're going to have to wake it up to remind it to eat. Stroking the bottom of the feet, rubbing on the baby, kind of waking them up, kind of sitting them up. The feeding pattern can change whenever mama's breasts become fuller. Usually 1.5 to 3 hours around the clock. It'd be about 8 to 12 feedings a day. We don't want the baby to sleep all night long because we're not sure how much they're getting, so we feed them more often. Formula babies every 3 to 4 hours, 6 to 8 feedings a day. We can tell whenever they're starting to get full, they'll have longer pauses toward the end of the feeding. Their body's going to get really relaxed. They'll fall asleep and let go of that nipple. And this is the same for breast or bottle. Breastfed babies that demonstrate feeding cues need to be offered the breast. Whenever they start rooting or acting like they're hungry, it's time to go ahead and put them to breast. And I'm sure in the hospital you've seen there are different positions. The football hold seems to be pretty popular while mom is in the hospital and in the hospital bed, side lying positions. And whenever she's switching sides, different positions should be encouraged because, especially if she's developing some soreness or has a lot of engorgement, different positions will help release that milk. The infant needs to attach its lips to the areola, not the nipple. If it's just sucking on the nipple, she's going to get very sore. You want the infant to open its mouth really wide and draw the baby in. You want to watch the baby, make sure it's sucking, and you want to see those joints in the mandible area to be moving, and you want to see the baby swallowing. You can hear him swallowing, and this provides a teaching opportunity. So, what are the feeding patterns? What happens if they're not tolerating formula? Usually they'll start spitting up. Teach them how to store their formula. Needs to be in the refrigerator. Do not heat it up in the microwave. If they going to need. How do I keep those bottles clean? There's powdered, there's concentrate, ready to feed. It's very important that you're not diluting the nutrition, so that she has to follow the instructions. We have to talk about safety and sanitary precautions, type of water to use. The baby needs no fluoride before 6 months. And burping frequently. Newborns need a slow flow nipple. They don't need a bigger nipple where that formula just pours into their mouth. Older babies can graduate to medium flow and high flow. The nipple shape is very important for breastfeeding babies because if they're going to be getting its breast milk, they need a nipple that they will take. Or sometimes breast babies get supplemental formula. Values. Some mothers believe that getting angry is going to mess up their milk production, or there's disapproval of breastfeeding in public, or they believe that colostrum is unclean. How long a mother breastfeeds her infant can be from 1 to 4 years, and this has some cultural significance. And if the practice is harmful, that's when we intervene. We don't judge. If they want to still be breastfeeding when the baby's in preschool, that's up to them as long as it's not harmful. Other cultural influences are naming traditions. They have certain umbilical cord practices. There's different parent-infant contact. Some beliefs all males are going to be circumcised before they go home. What are their beliefs about touching or not cutting the nails or the hair? It's important that we invite them to talk to us about their cultural beliefs. It'd be very interesting for us to learn about that and let them know that we do support them. Safety, preventing abduction, those ID bands, if they are missing, on the side of the guide replacement. If an electronic tags keep them within the system, if news comes off, somebody needs to know about it. Only with proper ID Never leave a newborn by themselves in a room. Mama's taking a shower, you stay in there with them. Never lift a newborn if you're feeling weak, faint, or unsteady on your feet. That's why we tell moms in the hospital not to be carrying your baby around in the room, roll them around in the crib. Always keep your eyes and hands on the newborn when they're out of the crib because I'm telling you, newborns will roll. Protect them from infections, good hand washing before and after giving care. Ask visitors who are ill or have sores or anything contagious, please. We have to be the role model. We have to show mom the proper position for the baby for back to sleep, watching for excessive mucus so that we can teach mom how to use the correct method of bulb suctioning. Never leave the baby by themselves anywhere but the crib. Not ever anywhere except that crib. Don't lay them on the couch and walk off to get something. Don't put them on a changing table and go reach for a diaper because they will roll. Never leave them alone because of security and because of frequent speeding up. Car safety, have to go home in a car seat that will fit the newborn. Never in the front seat with a passenger side airbag. Car seats for newborns are always rear facing until the child is 2 years old or the car seat reaches the maximum height and weight. Encourage car seat installation inspection. Usually, there is someone in the hospital who has been certified on placing a car seat in the car that can do this. Common concerns. Eyes will sometimes look inflamed or a little swollen, especially like one time we had a national shortage of erythromycin and we had to divert to gentamicin, and these babies' eyes would be so red and swollen. So we have to talk to parents about if their eyes are red and swollen, what happened. We want to facilitate bond, especially during the period of activity. Help to make it more choice of the baby. Baby doesn't have good head control yet. How to hold and feed the baby at the same time. Change diapers, cord care, circumcision care, normal voiding and stooling patterns. And all these skills and cares are in your little skills book that came with your textbook. Parent education. While we're providing infant care, we need to be teaching. Every time we're contacting the parents or going in the room, that's another opportunity for teaching, not waiting until it's time for them to go home and we hand them one of those books with their discharge papers. Teach them about feeding techniques and teach them about bathing techniques and teach them, mom, while you're eating, um, it's a good time to feed the baby. Teach by example. This helps to enhance confidence and positive feedback. Teach them about hand washing, circ care, cord care, when is the period of reactivity, what's expected in newborn responses, and normal physical characteristics of the newborn. What's expected during the bonding process? Are they bonding? Is the infant capable to interact? Find some positive aspects about the infant that may be having problems because they can still interact in their own way. What is the role of touch in facilitating parent family interaction? Comforting techniques, progression of infant behaviors, and information on educational materials. If they need more, then Give them more, give them other resources, and teach them not to just go Googling. Unless her care methods are harmful and she's accustomed to these methods, go ahead and reinforce what she's doing. If she's just got a little something wrong, help reinforce that to help correct her. You don't want to contraindicate and say, oh, you're wrong, you can't do it this way. Reinforce what she's doing, help support her, give her good positive feedback so that she'll go home and feel good about herself, knowing that she's going to be able to take care of this baby and be a good mother, good father, good family, and everything all set, and they can be excited. All right, that's it.